Welcome back. We're now going to take your questions, and I'm going to ask the panel a few questions on your behalf as well. So, does anybody have a question to start with, a burning question that they would like to ask to anybody on the panel?
Thanks. In the first part of your presentation, you talked about the loudness of tinnitus. I wonder how you measure the loudness of tinnitus, because it's surely a perception in your head.
Exactly, and so there are different ways to estimate the loudness of the tinnitus. The one that we have used is called visual analog scale. So it's asking the person who perceives tinnitus to rate the loudness of their tinnitus from 0 to 10. We explain for them that 0 means no tinnitus, and 10 would be the loudest possible. And that number that they give, that would count as the loudness, tinnitus loudness on that visual analog scale. It is variable, but this visual analog scales have been used for other things as well, like for measurement of the pain, another perceptory thing. There are other measures that I haven't used in my research to measure tinnitus, which I think Brian has done some studies on them.
Yeah, another method that has been used is to present an external sound and give the person the knob so that they can adjust the intensity of that sound and ask them to adjust it until its loudness is the same as the loudness of their tinnitus. Many people find that quite difficult to do. And one problem is that it doesn't necessarily capture how loud the tinnitus is in everyday life. It just captures how loud it is at the moment when you measure it in the laboratory. So it doesn't give a complete picture. And there are various problems in interpreting the results. So the method that Hashir described is the most straightforward. Just get the person to rate it. And most of us are familiar with this with pain. Often if you go to your doctor, they'll say, well, on a scale from 0 to 10, how painful is this? You know, and you can give a number, and you can do the same for the loudness of sounds, and it seems to be reasonably reliable. So that's I think our preferred method that we use.
This, if I add, is not tinnitus related, but during the COVID pandemic, I called my dentist. And I said, well, I have toothache. And so on a scale from 0 to 10, how painful it is. I was thinking, what number should I give for them to see me?
We had a similar question. I think that pretty much mirrors some of what you've said.
Exactly. Or with the brain scan. Any type of the brain scan.
So the question is, can tinnitus be measured or quantified by any type of brain scan or measurement of electrical activity? This is a difficult thing to do because many areas of the brain are active simultaneously, so how would you know sort of where to look to find something that corresponds to tinnitus? It can be done in some cases. People have what is called somatic tinnitus. Their tinnitus can be modified by pressing on the face or the neck or somewhere, but the sensation of pressing on the skin actually changes the tinnitus sensation. In my own case, my tinnitus changes when I shake my head like that. So you can do a brain scan for these people with that kind of tinnitus, where you look for changes when you sort of press on the trigger point on the head or the body where the tinnitus changes, and get an idea in that way. And such changes have been used to detect tinnitus. As far as I know, the brain scans or electrical activity have not been used to quantify tinnitus, to estimate how loud it is, for example, or how bothersome it is. But there is, at least from these people where the tinnitus can be modified by touch, you can see some areas of the brain that respond when that happens. and consistent with the sort of model that Don was talking about, this can show up in the limbic system as well as in the auditory system, for example, the parts of the brain that respond to sound.
So this is one of the huge problems of tinnitus research. It's one of the things that really is holding us back, is that there isn't an easy way to measure it. It's not like blood pressure, and it's difficult to know if the treatments that we do are making a real effect. What we want is what is called an objective measure of tinnitus, something that you can actually stick a number on that isn't needing the person with tinnitus to put an X on a line or to fill in a questionnaire or anything like that. All the things that we do have are called subjective, so they need the person to supply the information. And if we did have an objective measure, it would make our lives a lot easier. We've looked at a lot of things. We have looked at MRI scans, and we have compared. So there are two sorts of MRI scans. There's the sort that you have when you go to hospital, which is looking at the structure of your body, and then there's something called a functional MRI scan, and that shows bits of the body that are more metabolically active. And if you compare people with tinnitus and people without tinnitus, you do see different bits of the brain being more active in the tinnitus people. And as Brian said, it's not just the hearing bits of the brain, it is also the emotional bits of the brain. It's the same bits that you would expect to see lit up if someone had anxiety or depression. We've also looked at stress hormones. We've also looked at EEG, electrical activity in the brain. We've looked at various other chemicals in the blood. At the moment, we don't have that objective measure. We're trying again to see if we can revisit that. The British Tinnitus Association is leading on a big project called a Tinnitus Biobank, which is going to try and get information from thousands or maybe tens of thousands of people with tinnitus and compare them to people without tinnitus to see if we can find something that can be used as an objective measure. But yeah, it's a big problem.
I think I'll just add something. Now that British Tinnitus Association is working on this idea, I always thought that in the fMRI studies, when they shown some increased activities in the people who had tinnitus, as you discussed already, they also have anxiety and other symptoms which can also lead to that increased activity. Perhaps those fMRI studies should be done on people who have tinnitus but are not bothered by it.
Yeah, and there's always a chicken and egg to have they got the anxiety because they've got tinnitus, or have they got tinnitus because they've got anxiety? It's a very complicated thing. We've got a very patient hand waiting.
Let's take a question there at the back. We've got Laurie and Daniel here with the microphone.
Just following on from that, so some of the early studies in patients with psychiatric disorders were looking at people who had had brain injuries, and that's how some of our early research into understanding how different personality disorders and things developed. Has there been any research with patients who've maybe had strokes in different areas of the brain or other neurological or cardiovascular diseases that affect the brain to see, because there seems to be a body of evidence suggesting this is a neurological condition as much as it is, or even more so, than an auditory condition. So is there any sort of almost reverse research in that way to see people who've had other conditions and see if they have a higher incidence of tinnitus or hyperacusis?
Probably you should comment.
So, yeah, we have, again, we've looked at the coincidence of various conditions, both with tinnitus and with disorders of loudness perception. And there are a few, so tinnitus and anxiety, tinnitus and depression, tinnitus and hyperacusis, and vice versa. Hyperacusis people are more likely to have tinnitus. And then a lot of the things like chronic fatigue syndrome, less so with the evidence on things like hypertension is much weaker. It is mostly things that have a psychological basis rather than a physical basis.
Hands at the back there.
Yeah, thanks for that. Could you tell me how rare it is to get tinnitus in one ear only and why?
Very common. Yeah. So if you look at everyone who's got tinnitus, if about just over half have tinnitus that's either in both ears or in the middle of the head. Just over a quarter have it in the left ear, and just under a quarter have it in the right ear. And no one knows why left tinnitus is more common than right tinnitus. It just is. Even if you divide people up into whether they're left and right-handed, you still get the same. Some people also have it as a sort of around them, not inside them sensation. And that's particularly so at early stages of tinnitus. And it's quite a common story in the tinnitus clinic to hear someone say, "Oh, I got this noise and I drove myself potty for the first fortnight, going around the house, turning off all the appliances to see where the noise came from." And suddenly when I went on holiday to Greece and I realised that the noise had followed me, and it then jumped inside. So where people feel their tinnitus is kind of the best guess as to where it's their brain trying to make sense out of something that it doesn't fully understand.
There's a new study that Dan, Brian and I collaborated on. We assessed the audiological factors as well as psychological factors between people who have unilateral tinnitus and bilateral tinnitus. The study actually is not yet published. It will be published in the next few days. So you are hearing the news of tomorrow. And there was, in people who had unilateral tinnitus, there was a bigger gap between the hearing thresholds between the two ears. The ear with tinnitus had worse hearing compared to people with bilateral tinnitus. And also, there was no significant difference in the impact and annoyance and loudness of the tinnitus between unilateral and bilateral. So in terms of the psychological effect of it, because I hear that all the time, the patients who have only tinnitus in one ear, they say, "Oh, it's much worse because it's not balanced." People who have it in both ears say, "Oh, if I had it only with one ear, I could cope, but now it's in both ears." So the study showed that, whether you have it in one ear or both ears, it could be equally annoying. And so.
We had some raised hands over here, this side of the room. Yes.
Hi, thank you. So 2 questions, if that's not too greedy. And you may have already started answering this. So any research to indicate metabolic health, so that tinnitus comes from poor metabolic health? And then the second question I had is the use of hearing aids. If one starts exploring that, sort of, is there any indication that tinnitus could be more pronounced, or just open to the panel? Any of your thoughts? Thank you.
Do you want to start?
Yeah, maybe I can answer. Let me answer the second part first, about hearing aids. We discuss this issue in the book, and we suggest that people should only get hearing aids if they actually have a hearing problem, if their audiogram shows an abnormality, or if they have difficulties understanding speech, especially in noisy situations. Now, some people, when they're fitted with hearing aids, do say that their tinnitus seems to get a bit softer after a while, so they can help with that. But in the book, we suggest not trying to use hearing aids as an avoidance technique. If you have normal hearing, we don't think it's a good idea to use hearing aids just to try to reduce the tinnitus. But if you have a hearing problem, then that should be dealt with anyway, and it may incidentally help with tinnitus a bit.
And the opposite of that, I may add, that sometimes people, when they use hearing aids, they feel that it impacts on their tinnitus in a negative way. And specifically in people who also have hyperacusis, which are sensitivity to sound. Again, for those people, they start not using their hearing aids in the fear that it makes the tinnitus worse. And the advice is not to do that, because not using hearing aids in that circumstance become an avoidance behavior.
So there are some sorts of hearing loss that are amenable to treatments other than hearing aids. Particularly there's a condition called otosclerosis, which is a disease of the bone that conducts sound from the eardrum to the inner ear. And you can do an operation on that. And we know that people who have tinnitus in association with otosclerosis, the tinnitus is very likely to improve if they have the operation and the operation improves the hearing. So I think most of us, if someone has a hearing loss, the first thing we would do would be to try and improve the hearing loss. One shouldn't be able to get a hearing aid with normal hearing. No self-respecting audiologist would.
Well, if I can just respond to that. There's increasing evidence, I think, that people who have experienced hearing difficulties, even if their audiogram is within the normal range, get some benefit from low-gain hearing aids. And there's probably 3 or 4 studies out now showing that. And it may indicate that the person has some kind of underlying disorder that's not showing up fully in the audiogram, and just having things like directional microphones in hearing aids can improve the ability to understand speech in noise. But I agree, I mean, routine clinical practice is not to give hearing aids to people whose audiograms are within the normal range, but there are a number of research studies showing that even very mild hearing loss that you would still say is within the normal range can be associated with hearing difficulties where people can benefit from hearing aids.
The other example is people who've got a profound hearing loss, they've got no hearing at all, and even the most powerful hearing aids don't help. If they undergo surgery in the form of cochlear implantation, that is more likely to help associated tinnitus. It doesn't always. It's like everything in medicine. The words always and never don't really exist. But if there is something that you can do that will improve hearing, by and large, it's good for tinnitus.
Did that answer both of your questions?
Just the other question around whether there's any links between poor metabolic health.
Which specifically?
Blood sugar, dysregulated blood sugars, diabetes.
Yeah. Yeah. Without the figures in front of me, I can't remember if.
I was just.
Yeah. It's not a big association.
There are some links with diabetes and hearing loss.
Yeah.
And hearing loss.
Yeah. The diagrams I showed at the start, I mean, they showed that the auditory system is not just the ear, and the auditory brain is important, and that's important for the hearing bit as well as the tinnitus bit. How the brain processes the information is part of the jigsaw, and that's it all goes into something called auditory processing disorder, which was one of those abbreviations on my word map.
And an auditory processing disorder at one time was called central auditory processing disorder because it was assumed it was all in the brain, but now people tend to just call it auditory processing disorder because some of it may occur in the cochlea itself and some of it may occur in the brain, and you're often not sure.
We have progressed a bit in that it also used to get called obscure auditory dysfunction, which sounded rather pejorative.
We have a question here, blue jumper.
Thank you. Outside the door here, we have the Royal National Institute of Deafness. And you're talking about auditory. Would it not be a good idea to ask them about tinnitus and members?
But they have a tinnitus as part of their setup, and they liaise quite closely with the British Tinnitus Association. So yeah, that's already happening.
Good.
Yes, their main mission is to basically eradicate hearing loss and helping people with hearing loss. But tinnitus, because it's very common in people with hearing loss, it does come under one of their subcategories.
So if a person has severe hearing loss, they still can get tinnitus?
Yes. Yes, many people with hearing loss have tinnitus as well, about 60% of them. But tinnitus can be present in people who have normal hearing as well. And
We had a question around tinnitus starting after breast cancer surgery. And the question is it common to be triggered by illness or trauma?
For sure, anything stressful in your life can trigger tinnitus. And if you've got tinnitus already, any stressful event can make the tinnitus worse. Breast cancer is interesting. There's nothing specific about surgery for it that's any different from any other sort of major surgery. But some people with breast cancer also get treated with chemotherapy, in particular the platinum-based drugs, and they are one of the few drugs that has a definite tinnitus-causing action.
Yeah, I mean, those drugs can also cause hearing loss, of course.
Yeah, absolutely. I mean, that's probably... There are, although most, if you unravel that increasing bit of paper in the packet of tablets that you've been prescribed, almost all of them will feature tinnitus somewhere on it. Not very many people have to report tinnitus before the drug company has to mention it on the blurb that goes in the drug packet. But there are very few that it really happens to a big extent. The anti-cancer, some of the anti-cancer drugs are one. Some high-dose antibiotics, particularly something called gentamicin, high doses of aspirin, but it is very high. You wouldn't. We use, or not me personally, but some tinnitus researchers do animal research on tinnitus, and they use aspirin to generate the tinnitus. And the equivalent dose would be me having about 100 aspirin tablets. So the two tablets for a headache is not going to have the effect. And very high doses of quinine can also trigger tinnitus. But it's the sort of dose that you might get if you had malaria and were having to be treated for it. It's not the dose that you would get if you were going on holiday to somewhere with malaria and you were taking a quinine-based drug to prevent you getting it. And it's certainly not the dose that you would get in tonic water. I did the maths once, and you would need about 90 gin and tonics to give yourself tinnitus. I think probably by that stage you're not going to be too bothered.
When you say going on holiday, then. There's a question at the back. Yes, please. We'll bring the microphone to you. When you said going on holiday, I thought you were thinking of the bar rather than the malaria tablets.
Hi. I was just wondering if there's any correlation, or if you could shed some light on possible correlation between other hearing oddities. So, for example, I've got 4 different things. I've got the tinnitus. I have what I call white noise, so just a constant buzz the whole time around. I struggle differentiating sound, so in a conversation in a noisy area, all the periphery sounds, be it clinging glasses or whatever, are just as loud as the conversation in front of me. And the 4th thing is, yes, that hypersensitivity to sound. So if there's a conference meeting, we've got a speakerphone, my colleagues will put the volume up really loud to try and hear better, and for me it's better and I hear better if the volume's lower. But is there a correlation between those auditory things?
Probably you can.
Yes is the short answer.
Yeah. The thing is, many people with tinnitus have hearing loss. We think it's the hearing loss that creates the difficulties in understanding speech in noise. It's not the tinnitus, but many people with tinnitus are of the impression that the tinnitus is somehow interfering with their ability to understand speech. And there's no really direct evidence supporting that. It's probably that the hearing loss associated with the tinnitus that's producing the difficulties understanding speech, and not the tinnitus itself. I mean, it's a hard one to directly address experimentally, but our view we discuss this in the book, and our view is that at present there's no evidence that tinnitus itself interferes directly with your hearing. It may affect your concentration, of course, and it may affect the effort that you're willing to put into understanding, but we don't think that the tinnitus is having a direct masking effect on speech, for example.
And there was this study that I've done with a colleague, Richard Sulvey, one of those people who use aspirin to deafen guinea pigs. And in that study, we realized that there is a relationship between tinnitus loudness and severity of hearing loss. So the more severe hearing loss is associated with a louder tinnitus. And so a person with a louder tinnitus may find it harder to hear conversations. It may not be because the tinnitus is louder, it's because they also have a more significant hearing loss. And so again, to be consistent, the answer is yes, there are significant correlations there going on between tinnitus, hearing loss, and hyperacusis.
And you also noticed one of the things about hearing, that making something louder doesn't necessarily make it clearer, and that is very true. I had a personal demonstration of that. I was at a concert of the Blockheads, of Ian Dury and the Blockheads. The band continued even after he died, and they were very loud. And being a good ENT surgeon, I had some musicians' earplugs. So I put them in, and that attenuates everything by about 20 decibels. And not only was it much more pleasant, but I could actually hear the lyrics much better. Louder is not always better for hearing loss.
We have quite a sensitive question here, which is, my son suffers from hypoacusis and at times has been so depressed as to have suicidal thoughts. What advice can you offer to my wife and I about how best we can support him when he's feeling down?
Well, it's very complicated because definitely they need to be seeing a psychiatrist and be under their care. However, the psychiatrist can become a bit confused because of the problems of hyperacusis. And so ideally, they need to have two therapies parallel together. The priority given to the risks, so therefore the psychiatrist needs to take the priority, start the treatment, and then parallel with that, a specialist for hyperacusis can provide cognitive behavioral therapy to improve their management of hyperacusis. So the two need really to go together as far as I can say.
Question over here at the front.
It's leading on from that point, actually, hyperacusis, because my wife has developed really bad hyperacusis. She's also got very bad aggressive tinnitus. I've understood, yes, psychiatric, and I've understood CBT as well for that. But what about sound therapy? We've been told that sound therapy not only helps to be used as a tool to relieve the aggressive tinnitus as some sort of masker, but also can that, or is that a key tool to get that hyperacusis back under control?
So you're going to hear different stories from different people here. So the book goes into quite a lot of detail about not getting hooked on using sound to distract the brain from tinnitus. And it gives a very reasoned argument as to why that should be. And it's something that psychologists call safety behavior. And the book is clear that trying to break that cycle is good. I think hyperacusis is slightly different, because if you've got a problem with sound tolerance, and particularly if you've tried to make your life quieter and quieter, you think that that's sensible, but the more you withdraw from sound, your brain then goes, where's my sound gone? And turns up the central gain control, which makes the problem worse and worse. So the quieter you make it, the more sensitive your auditory system becomes. Trying to break into that is quite often helpful in my clinic. And using sound to desensitize that oversensitivity is helpful, and a lot of people would use sound therapy in that situation to try and improve the sound tolerance. Indeed, we have an expert standing up there against.
If I can pick up on that, I think it's more, can you use it as a tool to expose yourself in a way, like to provide sound to your brain, and because indeed people with hyperacusis feeling that sound is bad for you, it's doing something bad, but it's actually doing something good, so it can help to gradually expose yourself, which is in a sense also what's done in CBT, but you will expose yourself to sounds in the environment more, while sound generators can help you to expose yourself to a specific sound. So I think the two can go hand in hand and don't exclude each other.
When I was starting my sort of tinnitus career, sound therapy was very much the thing, and people were fitted with things that looked like small hearing aids, which were called maskers, and told to sort of use them to drown out or to partially drown out the tinnitus. I think most of us have moved away from that. We haven't completely disregarded it, but it's much less common now than it used to be. One other issue is in the bedroom, where we've all been persuaded to have highly insulated houses to save energy, and as part of that, it's also made them increasingly soundproof. And a modern bedroom is probably a quieter environment than the human auditory system was ever designed for. So you can make an argument for having some sound in the bedroom, but I do agree with what Hashir and Brian are saying and what is said in the book, that don't become over-reliant on that. And my advice to my patients is, if you want a bit of sound in the bedroom, then yeah, okay, but you want it at a very quiet level, so if you're pottering around, you aren't aware of it, but it's there as a kind in the background if there's no other sound. You don't want it loud, you don't want it trying to drown out the tinnitus, and if you're going to do that, perhaps it's best to get one of these devices, get one with the mains adapter, just switch the thing on and leave it on 24 hours a day, so it's not drawing your attention to it, it's not becoming one of these rituals that you associate with tinnitus. It's just something there in the background. Or get an indoor water feature, or the oxygenator and a fish tank, or something that's going to be there the whole time and it isn't part of the tinnitus routine. I'll now hand over to the don't do that brigade.
I think it's fair to say that there is research evidence supporting an approach of including sound therapy as part of the treatment, and there's research evidence supporting the sort of approach that Hashir and I have written in the book, which tries to not use sound to sort of as an avoidance behaviour. And I think the evidence at present is just not good enough to say one is definitely better than the other. Both approaches are possible. We think that at present the evidence base is stronger for this kind of cognitive behavioural therapy approach that we've adopted in the book. But more research is clearly needed, and there are some people who advocate sound therapy for hyperacusis, and the claim is that the levels that you find uncomfortable can be brought up a little bit by long-term exposure to sounds. So it's not a clear-cut issue. We can't definitely say one is better than the other. And I think, to some extent, you could try the different approaches and see what works for you. But we think that present the evidence supports the sort of approach that we have in the book that suggests not using background sounds as part of an avoidance behaviour.
And following that, I'm not aware of any study which compares CBT on its own, CBT and sound therapy, and to see whether I doubt that if there is any study like this, would actually show any difference. The only, we have been using a lot of sound therapy devices in the past, but in addition to education, counseling, other things that we were offering to the patients. And times again, when we were doing surveys asking people which intervention did help you the most in managing your tinnitus, three things usually came at the top. First, to my surprise, I expected to be CBT, but the first was counseling, as a person listening to me and understanding my problem. Any survey that we have done, this came first. The most important thing that helped another person to manage their tinnitus was to sitting with the therapist and the therapist listening to them and understand their problem. And the second, again, not CBT, was education. Learning about my condition helped them. And the third was CBT. And but further down the line were sound therapy using this device and hearing aids, so on and so forth. So there's only one problem is, yes, definitely I agree with Brian that, and also with Dan and Laurie, that, you can try, sound therapy, that's absolutely fine. But when you have a very severe case of hyperacusis or tinnitus, that severity basically means that there are a lot of psychological disturbances going on, and definitely they would need a CBT heavily focused on managing their tinnitus, and using sound therapy or other stuff like that is going to somehow sabotage the actual progress that they can make in that CBT program, because the message that the CBT it wants to promote is that you can sleep even when you're hearing tinnitus. But when they are using a sound in the bedroom, so the message that they get is that you can sleep only if you're using this sound. So the tinnitus doesn't become insignificant enough. So in CBT and other treatments that you have with tinnitus, you want to make tinnitus insignificant, so the brain doesn't focus on it. And CBT aims is for the person to get to this realization that I can do this and that without having to rely on any other activities. And that will basically make tinnitus very insignificant. But other approaches that have that problem, but the people who are not that much bothered by tinnitus or hyperacusis, yes, certainly they can try. But for severe cases, I think that focusing on a CBT approach combined with psychiatric support is the key to that. That's my own opinion.
Question over here.
Thank you. I've got lots of questions, but I'll keep it short. So I've had tinnitus for probably 10 years or more, and actually predominantly in the left ear, so I've learned something tonight about the left, right, unilateral, bilateral. In recent years it seemed to have increased, it's got worse, and I just wondered if there was any evidence or truth in any of the claims that COVID or even the jabs have brought about an increase in tinnitus. I seem to see a lot of it on the internet. I haven't done any sort of in-depth research, but certainly a correlation for me that the last couple of years I've had COVID and all the jabs, and does seem to be a pattern, but I don't know, is it just a coincidence, or is there any evidence to back that up now?
So way too soon to say. Come back and ask that question in 10 years, and then we may have a better notion. So there are lots of suggestions that, yes, COVID has made it worse. And you can see that there could be some direct effects there. We know that the coronavirus can affect the neural system, so it could have a direct effect. We also know that when it started, it was a major upset to our lives, and it was quite stressy. We didn't know whether we'd, get COVID and die. We didn't know whether we'd get loo rolls, and we didn't know, there were so many stress things going on. It also got much quieter, and we were also stuck at home and not interacting with other people as much. So there were a whole load of things that you would expect to make tinnitus worse, kind of indirectly there, as well as the potential for direct. The vaccinations, the reporting system suggests that yes, there have been some people reporting tinnitus with vaccination. But if you've got tinnitus already, and you've got to go and have the vaccine, you're going to get anxious about it, and you're going to, only naturally, you're going to worry about whether it's going to do something to your tinnitus. Just like if your GP wants to change your antihypertensive medication or whatever. And you do a thing called monitoring then, where you listen to your tinnitus to see if the vaccination is going to make it worse. And because you're listening and looking out for your tinnitus, it does go up. And it's the monitoring probably rather than the vaccine. But again, who knows for sure? The vaccines are novel treatments too. This type of treatments that have been used before. So we don't know whether they're going to have... We are the guinea pigs for this. We don't know if there are going to be long-term sequelae to it. We just got to wait and see. And you've then got to... we reckon... we don't know for sure the incidence of tinnitus. That's the number of new cases of tinnitus that arise each year. We're not completely sure about that, but probably it's about, your risk is probably about 1%, so 1 in 100. So that means that maybe there was somewhere around 600,000 people in 2020 who were due to get tinnitus anyway, just because that's how many people do normally. If they got tinnitus in the time of COVID, there is a tendency to blame it on the COVID, whereas it might just have been utter coincidence. It's very difficult to do that. It's one of those things where you would need to look and see if there's been an excess number of cases of tinnitus in that time period. But we don't keep really good records of how many people get tinnitus. Even from GP records, it's not wonderfully documented. So it may be that we never really answer that question, but it's certainly an interesting question.
That brings us up to 7 o'clock. I've got one more question that was handed to me. Should we do that one and make it the last one? So the last question is, to feel better, I like to understand my condition. How can I be hearing noises in my head if my ears are, in inverted commas, perfect, and the noise doesn't appear to be coming from my ears?
You don't need ears to have tinnitus, you need a brain.
There are two possibilities which Don alluded to. One is that your hearing may not necessarily be perfect, even if your audiogram is normal. And for example, we now know that with increasing age and with noise exposure, you can get damage to the connections between the hair cells in the cochlea and the neurons that make up the auditory nerve. And this is called a loss of synapses or synaptopathy. And by the time you get to my age, on average, you've lost 65% of the neurons in your auditory nerve, which follows on from this synaptopathy. So you might have a normal audiogram, but still have a hearing disorder that's associated with tinnitus. So that's the first possibility, which I think is quite a likely one. But let's say your auditory system is still functioning normally, at least the peripheral part. It's still the case that there are many central mechanisms that are constantly adapting to the signal that's coming from the periphery. And we know from animal experiments that if you just change the statistical properties of the sounds that an animal is exposed to, you get all kinds of changes in the central auditory system. And there's all kinds of balances between excitatory processes and inhibitory processes that are trying to turn things down. So you might have a perfectly normal cochlea, but some imbalance in these processes in the brain itself could lead to tinnitus. And one thing that we know, as you get older, there's a loss of so-called inhibitory neurotransmitters that are the ones that tend to push down the neural activity. And so an imbalance between excitation and inhibition in more central structures could give rise to tinnitus, even with a completely normal cochlea. So both are possible at this stage.
I think the cochlea is overstated in tinnitus generation, and there may be 3 people in this room with normal cochleas. The rest of us have all got some damage to our cochleas. We've been on the planet long enough. If that is true, then why doesn't everyone get tinnitus? If you look at the figures of if you live long enough, you will get a hearing loss. Yep.
Sure.
But if you look at the rise in tinnitus, it comes up and then it levels off. It doesn't keep rising forever like the hearing loss one. And there are lots of people who have hearing loss and don't have tinnitus. I think it's more to do with what's going on in the brain bits of hearing than the auditory periphery, though I accept that if you look hard enough, you will find some auditory deficiency in most people with tinnitus.
I wouldn't like to argue at all that central processes are not important. I think they are crucially important, but I think that sometimes the initial trigger for tinnitus may be an abnormality in the cochlea that leads to subsequent.
Sure, and that indeed, that's what I said, that one of the triggers is your hearing going down. But you in the clinic, you frequently hear, yeah, no, my hearing's been the same for years, it hasn't changed at all, but it happened after I had to go to court, or it happened after Mum died. There's an event, there's a life event attached to it.
Another possibility is that because tinnitus is a perception of a sound with no real sound being there, so you're hearing something that doesn't exist. I told this to one of my patients and he said, he kind of liked it, and he said, yes, I'm not going to let this sound, which even doesn't exist, to ruin my life. But you know, so you don't have to have a hearing problem for your brain to start noticing sounds or different things that that people with tinnitus may have.
Thank you. Should we thank the panel and thank all of you for your wonderful questions?